Hello, I'm Ann Solaris, and I'm presenting our research improvement of non-alcoholic fatty liver disease through a comprehensive weight loss program in a community gastroenterology practice. Non-alcoholic fatty liver disease, or NAFLD, is considered an obesity-related GI disorder. Other examples include acid reflux disease and gallstone disease. Obesity-related GI disorders are estimated to account for over 30% of patient visits to community GI practices. The primary therapy for NAFLD remains weight loss, as there's no FDA-approved medications that treat NAFLD. Studies regarding weight loss continue to show the benefits of structured programs over self-directed weight loss. In 2015, Villar Gomez and colleagues published a study that utilized liver biopsies to evaluate histologic markers for NAFLD activity. These included steatosis, hepatocyte ballooning, and identification of NASH. Their study demonstrated that in patients who lost greater than 10% total body weight loss, there was resolution of NASH and improvement of NAFLD activity. Despite education on diet and physical exercise, less than 50% actually met the goal of 7 to 10% total body weight loss. It's based on their study, roughly 10% of their participants achieved that greater than 10% total body weight loss that had been demonstrated to resolve NASH. Shortly thereafter, in 2016, Hanna and Harrison reviewed the expanding research on NAFLD management and developed the diagram seen on the right of the slide. This demonstrates the additional improvements noted in histologic markers with increasing amounts of weight loss. You can see on the bottom that steatosis improves with the least amount of weight loss, and subsequently with greater weight loss, there's more improvement of NASH and fibrosis. The Power paper was published by the AGA in 2017 and provided targeted guidance on the management of obesity and really emphasized the unique role of GI providers in its management. The Huron Gastro Wellness Program was created by deploying the principles presented in the Power paper. It was developed in 2017 and centered on the 4 pillars of food and nutrition, exercise, sleep, and mindfulness. The program was designed to cover a curriculum spanning the 12-month enrollment period focused on these pillars. A multidisciplinary team of providers, dietitians, and a nurse navigator was created that would meet weekly to continue to evaluate participant progress and individual needs. Participants were primarily referred by their primary care provider given a concern for NAFLD or following a GI visit in terms of management. Each participant underwent routine lab work and transient elastography at time of enrollment. They also would undergo an in-office body composition analysis to better detect weight distribution. At the initial visit with a provider, they would utilize clinical scoring tools such as Hepatic Steatosis Index, or HSI, NAFLD Fibrosis Score, and FIB-4 scoring to better assess with detecting advanced fibrosis or advanced NAFLD. Using these clinical scoring tools would allow for a discussion based on the role of obesity as it relates to their overall health and enable the provider and participant to reframe the focus of weight loss into a tool for reversal of fatty liver disease. During that visit, the provider would discuss a goal of greater than 10% total body weight loss, if appropriate for the participant, given the prior data demonstrating resolution of NASH and reversal of fibrosis at that time. Participants would also be instructed about having repeat laboratory and imaging studies throughout their involvement. The program is structured as an algorithmic approach predicated on the Power principles. During the initial stage of the program, nutrition serves as the primary focus. Participants follow a low-calorie diet through meal replacements for the first 12 weeks, then transition to a plant-predominant diet. They also have access to 12 one-on-one visits with a registered dietitian to further individualize their weight loss plan. Support groups serve as a cornerstone and are currently in a virtual format. They initially begin as weekly for 16 weeks, then transition to bi-weekly and then monthly. These groups allow for both peer support and encouragement, while allowing for discussions facilitated by the registered dietitian based on the developed curriculum. As the program progresses, the curriculum evolves to incorporate additional guidance on physical activity and mindfulness, with participants available to access weekly exercise classes and have 4 sessions with a mindfulness coach. Since 2017, over 600 participants have been enrolled in the Huron Gastro Wellness Group. The diagram below demonstrates the percent weight loss at 3 months from a prior retrospective study, with the x-axis representing percent weight loss and the y-axis being the number of participants meeting that category. As you can see, 65% achieved greater than 10% total body weight loss at 3 months. When participants were surveyed, 52% reported symptomatic improvement in acid reflux, and 38% reported reduction in type 2 diabetes medications. Our current aim was really to assess the impact of a structured community-based weight loss program on NAFLD activity. Our study was designed as a retrospective analysis to look at participants enrolled from January 2019 to June 2021. 308 participants completed the initial intake forms, with 77 completing the full 12-month program. Of those 77 participants, 48 of them completed the program and achieved a greater than 10% total body weight loss. 25 of the 48 completed laboratory evaluation with transient elastography as well, at both the time of enrollment and conclusion of the program, allowing for analysis. Exclusion criteria for our study included a diagnosis of cirrhosis, alternative cause of liver disease, an age less than 18 years old, and then any pregnancy during their enrollment time. In our cohort, the group analyzed had an average age of 55 years old, with 52% being female. The baseline weight was 245 pounds with a BMI 37, and the average time between the initial transient elastography was 7.2 months. We completed a comparison of the steatosis and fibrosis scores determined by transient elastography. On the graphs below, the x-axis indicates the numerical score, while the y-axis represents the number of participants. The left diagram demonstrates the significant improvement in steatosis scores from 2.24 to 1.64. The right diagram shows the improvement in fibrosis scores from 2.04 to 1.52, with a general leftward shift toward lower fibrosis scores. However, this result lacked statistical significance. Paired t-test analysis was completed for HSI, NAFLD fibrosis scores, and FIB-4 scoring. The left diagram on the slide demonstrates the statistically significant improvement in HSI from 50.48 to 41.23 with a p-value less than 0.001. The diagram on the right demonstrates the statistically significant improvement in NAFLD fibrosis scores from negative 0.8 to negative 1.35 with a p-value of 0.01. However, the FIB-4 scores had no significant change, with the scoring results increasing from 1.22 to 1.38. In summary, our results demonstrate that achievement of total body weight loss greater than 10% through a comprehensive wellness program resulted in improvement of steatosis scoring on transient elastography, HSI, and NAFLD fibrosis scores. There was a trend towards improvement in fibrosis scores on transient elastography. However, this lacked statistical significance. Our results demonstrate the success of incorporating the power principles at a community GI practice. Completion of the 12-month program led to 62% success rate at achieving greater than 10% total body weight loss. The program allows for patients to better understand the relationship between lifestyle and NAFLD, provides them with the tools to reverse their disease without additional medication. The program provides a reproducible format that builds on the cornerstone of support groups to cover a broad curriculum on wellness. While the improvement in fibrosis scores on transient elastography was not statistically significant, It does represent a clinically significant change that would be better analyzed with a larger sample group. The cohort consisted of community participants who had a lower baseline fibrosis score as seen on the diagram on the right. We can also see on the diagram that with the higher fibrosis scores, the number of participants did decrease with total body weight loss greater than 10%. In our participants who did achieve that goal weight loss, the average time between the repeat transient elastography was 7.2 months, which is likely too short of an interval to detect a significant change. Of note, regarding the FIB-4 scoring that did not change significantly, this is likely attributed to the fact that the scoring calculation does not incorporate weight or BMI. Further investigation is needed to assess whether fibrosis scoring on transient elastography significantly improves with a longer interval of follow-up. We also hope to explore whether improvement of NAFLD activity impacts the quality of life for patients. There continues to be a need for non-invasive tools for the diagnosis of NASH, as this currently relies on biopsy. And as new medications are developed specifically for NAFLD and NASH, they will need to be closely compared to the standard of weight loss, given the costs and possible risk associated with pharmacologic therapy. A major limitation to our study was our small sample size due to participant retention. In some cases, this was due to failing to have in-office follow-up, and in other cases, this was due to participants not attending support group, which meant that they could not continue with the designated curriculum. Another limitation was failure to complete repeat labs or transient elastography. This was also partially due to the COVID-19 pandemic, as there was limited availability for in-office testing for the transient elastography. Another limitation is that there was no further follow-up for participants after the 12-month curriculum to determine maintenance of weight loss or continued improvement. In conclusion, our study demonstrates that a structured community-based program can improve NAFLD activity as demonstrated by improvement in steatosis scores, HSI, and NAFLD fibrosis scores following weight loss. Community-based programs remain a valuable resource in the management of fatty liver disease. Our cohort had 62% of participants who completed the program achieve their goal of greater than 10% total body weight loss. As mentioned, further research is needed regarding the lack of improvement with fibrosis scoring on transient elastography. And through our program, we hope to continue expanding our understanding of obesity-related GI disorders and the role for community GI groups. Additionally, here are our references for our presentation.